Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, thank you so much for joining us for Conversations in Acute Myeloid Leukemia, Novel Therapies Targeting the Immune System for Elderly and Unfit Patients. During this segment, we will discuss targeting the immune system in AML and the rationale, efficacy, and perspectives. I am Dr. Eunice Wang, Chief of the Leukemia and Benign Hematology Services and Professor of Oncology at the Rosewell Park Comprehensive Cancer Center in Buffalo, New York. I am joined today by my esteemed colleagues, Dr. Tapan Kadia and Dr. Daniel Pollyea. Today we'll be talking a little bit about AML and the immunosuppressive and immune microenvironment of AML and strategies for how we might be targeting and utilizing immune-based strategies, whether it be activation of T cells, suppression of MDSCs, or delivery of drugs via antibody-directed approaches for the treatment of AML in this specific elderly and unfit patient population. So to start off with, we know that AML cells create an immunosuppressive environment, and they are associated with alterations of the baseline microenvironment that the leukemia cells sit in to promote leukemia growth. We all know that activation of the T cells in the immune system can lead to anti-leukemic activity, as evidenced by the fact that we have successful cures, even in this day, with allogeneic T cell directed therapies, donor lymphocyte therapies, allogeneic stem cell transplantation. Many studies have been shown that T regulatory cells and myeloid-derived suppressor cells are increased in patients with AML, and that activation of normal T cell responses are depleted or suppressed in these AML patients. And that has led to much interest in strategies that are going to promote or activate T cells and other arms of the immune system to supplement the current therapies that we have for acute myeloid leukemia. We know that intensive chemotherapy has been the backbone. We now know that less intensive targeted therapies may be just as useful, but what about immune therapy? So I'd like to turn to Dr. Kadia and have you talk to us a little bit about maybe immune cell targeting. Like if we are going to target the immune systems, what are the targets on AML cells that represent potential modalities of interest?
Thanks, Eunice. Yeah, great introduction. I mean, I think you really crystallized why we need to really be creative with our immune therapies in AML. AML, being in the bone marrow, has a microenvironment that is itself immunosuppressive. So there are many challenges. I think one of the big challenges when targeting AML with immunotherapy is to find the right sort of surface target antigen epitope that we can use that differentiates AML from, let's say, other normal cells. In ALL, acute lymphoblastic leukemia, we're fortunate in that CD20, CD19 are two great targets that are sort of different than all the other cells, and we can afford B-cell depletion. But in AML, many of the targets that we see on myeloid cells are also present on hematopoietic stem cells and other normal cells in the body. So we get off-target toxicity, we get severe myelosuppression. Some of the targets that have been sort of recognized and investigated, CD33, a target that's present on blast, AML blast, but also myeloid precursors and some hematopoietic stem cells, has been a target for many years. We have an ADC, an antibody drug conjugate, gemtuzumab ozogamycin, which carries calicheamycin 2CD33. It was approved for AML and reapproved recently for all types of AML. We see benefit in patients who have favorable risk AML. So it's an immune therapy where you're targeting specifically CD33. We see some off-target effects, specifically maybe some liver toxicity, VOD, because the endothelial cells of the liver sinusoids may have CD33 positivity. Another target is CD123, again, present on AML blast stem cells, maybe not on hematopoietic stem cell precursors. There are some targeted therapies now being developed. In fact, we have one approved now. SL401 or tagrascafusp is approved for a disease called BPDCN, where the CD123 is highly overexpressed. It's sort of a relative of AML. We're now studying it in acute myeloid leukemia. and there's some other investigational ones available. CD70 was targeted at one point with a drug called cusatuzumab in combination with decitabine. Initial results looked pretty good, but I think further studies suggested that maybe it was not better than just decitabine alone. So I think the challenges remain sort of finding the right epitope surface target for antibody-directed therapies, whether they be antibody-drug conjugates or bispecifics. I think trying to overcoming the microenvironment and the tumor suppressive microenvironment, the heterogeneity of AML, how you sort of lose antigen. So I think those are some of the challenges, but those are some of the targets that I think. I'm not sure if you have other ones.
Right. I mean, I think one of the interesting things is we've really tried ever since gemtuzumab to attach different things to our antibodies, whether they be CD33 or CD123. So we've thought about antibodies as kind of delivery systems for targeted therapy for AML blasts. And again, as you mentioned, targeting surface antigens that are preferentially expressed on AML cells. I think CD123 or IL-3 receptor alpha really was targeting more leukemic stem cells. But we've used these to deliver other things. So I don't know if, Dan, you want to comment on what about using antibodies to deliver, other things? What about delivering radiotherapy, or what about other toxins? What about, do you want to talk a little bit about some of our antibody-directed approaches?
Absolutely, yeah, thanks. I mean, there's a bunch of different ways to think about this. Like you said, is this the sort of guided missile with, some sort of poison attached, whether that's like a very toxic chemotherapy-like drug, as is the case with gemtuzumab and other similar derivatives, whether you use this as a way to take a radio-labeled isotope into that as the payload into the target of interest. Or, I have kind of a not unique, but a fresh perspective, having come off our recent inpatient service where we treat all blood cancers, and it seems like every third patient now is a myeloma patient being treated with some new, really cool bispecific antibody. It's amazing what they're doing. And I think in the AML world, there's the potential for us to do that as well, to link things to CD3, as we have done with blinatumomab and ALL, but to have this be focused on myeloid targets. And I think you guys covered really well the targets of interest, 33, 123, and some of the potential problems with those. But maybe a better way to think about this is sort of like, who are the patients who have the highest expression of that target and employ these treatments for those patients, and that's sort of what has happened, like Tap was talking about with BPDCN, the CD123 focused therapy works well in a disease where almost uniformly there's very high expression of CD123. So can we learn that lesson and really kind of direct those types of therapies to AML that has high CD123 expression? Is that the way to do it, instead of thinking about these therapies as sort of one size fits all for AML? But I think there's a lot of reason to be excited. And again, I came off pretty inspired from my recent 2-week stint on the inpatient side with what myeloma and lymphoma people are doing with bispecific antibodies. And I want us to do the same.
Yeah, I mean, I think that's a great example. I mean, I think we've certainly seen antibody drug conjugates make their way into AML therapy with gemtuzumab. We've had some disappointments. We've had some Seattle Genetics CD33 antibodies conjugated to toxins that didn't go anywhere. There is recently a great deal of interest in attaching different things. So we've certainly now seen a CD33 antibody, lintuzumab, attached to an alpha particle emitter, the actinium-225. And in the last couple ASH meetings, been seeing some activity of that both as monotherapy and in combination with high-dose chemotherapy. And then, as you talked about, I think there's a great deal of interest both in CD123 targets. Maybe that's a better way to target AML cells and the AML leukemia stem cells, and then maybe the bispecifics. So in terms of CD33 bispecifics, we started with CD33. We all use blinatumomab for MRD positive ALL, and there's been a great deal of interest initially in CD33, CD3 constructs. We saw that with flotuzumab, right? That DART bispecific antibody-based molecule that was combining a CD123, CD3, and really was really effective in primary refractory AML, right? But low response rates, but really a lot of cytokine release. Then we saw the Amgen molecules, the AMG 333, which was that CD33, CD3 bispecific, just like blinatumomab, but that was 14 days, 28 days of continuous infusion. Amgen has developed a shorter half-life drug, the AMG 673, but that again, limited efficacy. So I think we still have a little bit to go in terms of our myeloma colleagues in developing a successful bispecific that really has efficacy. There's more data now with the newer drug, this VB-cetomab, which is, again, another, I don't know if anybody can say that word.
I call it XMAB.
XMAB. So have you had experience with that drug?
I have, and I think what you and Dan said is spot on. I think that, we really wanted blinatumomab for AML. We wish we had one, right? We thought it would work just as well. But what we see is, like you said, the flotuzumab, the AMG 330, and now XMAB, which is a CD3, CD123 bispecific. So I think one of the things that we learned from treating people with AML who tend to be very proliferative of high burden disease is what if we actually use these antibodies, these bispecifics in a clinical setting where there's a very low burden of disease, where the immune system has a chance to sort of overcome some of the proliferation and the excessive microenvironment that AML brings with it. And so what we've used is this XMAB, this vivotoximab, or a CD123, CD3 bispecific in patients with positive minimal residual disease. So just flow positivity, no morphologic evidence. And we've seen some responses, right? We've seen some decline in the levels of MRD undetectable in future. And so, is that going to translate into survival or reduce risk of relapse? We don't know yet. But I think that's one strategy that we can consider. Because remember, blinatumomab started and was first approved in MRD positive ALL and later on became used in relapse refractory or frontline. So I think, could that be a strategy? I'm not sure what you guys think.
I mean, I think that all of the studies with these bispecifics, I think there's been issues with targeting which antigen, issues with infusion, continuous infusion versus short infusion. I think they're now looking at subcutaneous blinatumomab or subcutaneous bispecific. And then, as you mentioned, tumor burden. Obviously, these are not patients because of the risk of cytokine release and because of the high tumor burden that we're really going to see a response in a patient that has hyperproliferative AML. So I think that those are all things that we need to think about as we move forward with these agents in AML. Dan, what about the PD-1, PD-L1 inhibitors? I know there's been a lot of success in lymphoid and in solid tumor, but do you have any thoughts on nivolumab or some of these other PD-1, PD-L1 inhibitors and antibodies?
Yeah, thanks, Eunice. I mean, not much enthusiasm from my end about these strategies. I think Top's colleague, Novel Dover, and maybe Top as well, have presented these in past years, and I don't think it gave us the sort of enthusiasm, at least as single agents, to really think that there's too much of a future there. So this isn't a field that I've been terribly excited about, and especially disappointingly, given how well these can work with some of our solid tumor colleagues.
Yeah, I mean, I think in the relapse setting, I think that Dr. Dauber did show that they did, the response rate's low, even with combination with azacitidine, but that there was some responders that had what seemed like a less depleted, more activated, because I think a lot of our relapse refractory patients have gotten a lot of myelosuppressive therapy, and patients that really had an exhausted immune phenotype really were not able to get any benefit from these agents. And there might be something there for some sort of immune profiling to predict. We also know certain biological subsets like P53 mutant, there's been data showing those patients are incredible or in very specific ways have defects in their and maybe innate and adaptive immune systems, and that might be part of why they do so poorly. So I think that although we think in general, and I hope you would agree with me, that these immune therapies are incredibly appealing because they're theoretically less toxic and myelosuppressive in these elderly immune and unfit patients, we still have a ways to go. Is that what you would agree with, or is anybody incredibly excited about these? I mean, I think the response rates overall have been sort of low 20, 30%. I think maybe the XmAb would be a little bit higher, but I think unless we're talking about antibody drug delivery systems, the pure immune activators, I think we've been a little bit disappointed.
Yeah. I agree with you, Eunice. I think that these have been disappointing, at least the ones that we discovered or went through so far, including the PD-1, PD-L1 antagonists, the bispecifics. I think if there's any signal, it's probably the antibody drug conjugates, like you mentioned, where they're actually bringing chemotherapy or some radiotherapy to that site. I think we really need to understand the immune system better and what works for AML. It might not be T cells necessarily. Could it be NK cells?
Right.
They've got targeting, they've got these trikes now, which are tri-specific antibodies similar to BiTEs, but instead of targeting T cells, they target NK cells. So they target the antigen and they have two receptors on the NK cell that either bring the NK cell but also have a stimulatory domain. So there are some of these that are in testing. Is that the answer? I'm not sure. But I think that we still have a lot of learning to do, like you said.
And maybe targeting myeloid-derived suppressor cells or NK cells or macrophages. I think the disappointment with the T cell sort of activation pathway, I think, has prompted people to look elsewhere. Dan, any final thoughts from your?
No, I think that's a great discussion, and I think the macrophage issue we're going to be discussing a bit more in segment 3. So it's a good transition to that.
All right. Well, thanks so much. I really do appreciate all of you for joining us for this segment on targeting the immune system in AML. Please be sure to click on the landing page for this activity to claim your continuing education credit, access supplemental slides, as well as other topic segments from this program.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.